Hello guys, this is Krishna from Carco City. So today we shall be discussing one of the important topic, right? It is actually anti-diuretic hormone ADH. So this is one of the most important topic in Krog 1 examinations, at the same time the remaining exams also, remaining medical exams, right? So first of all we'll start from the anatomy. Anti-diuretic hormone, first of all, from where is it secreted, right? First we shall discuss uh, the secretion of the antidiuretic hormone, and later on we'll discuss the mechanisms, and next the third step we'll discuss some clinical aspects of antidiuretic hormone, right? As you know, the other name for antidiuretic hormone is vasopressin. Vasopressin. So I'll explain you later why is it so called as vasopressin, but for now, antidiuretic hormone is produced from your, is secreted from your hypothalamus. Look, exactly speaking, for example, this is your hypothalamus. This is your hypothalamus. Hanging down to your hypothalamus, there is pituitary gland. So there are two divisions of the pituitary. This is the anterior pituitary and this is your posterior pituitary. Anterior pituitary are also called as adenohypophysis. Adenohypophysis are also called as anterior pituitary, and this one is posteriorly located, called as the posterior pituitary, are also called as neurohypophysis, right? Coming to the anterior pituitary, look, this is the hypothalamus. Pituitary gland, this entire thing is called as a pituitary gland. Where is exactly pituitary gland located? Pituitary gland is located in the sella turcica of the sphenoid bone. Look, in the sphenoid bone, so this is inside, you can find it, find your sphenoid bone when I take out the skull cap, and in the sphenoid bone there is a structure, one of the part of the sphenoid bone which looks like a Turkish saddle. So exactly located within that there is your pituitary gland. Fine. Now coming to anterior part of the pituitary gland or adenohypophysis, there are several hormones which are released from this anterior pituitary. Coming to the posterior pituitary, there are only two hormones which are released from posterior pituitary, right? So one is your oxytocin, is ADH. So this is most important. No one is going to ask you what are the hormones that are released from anterior pituitary, because there are many of them. But from the posterior pituitary, there are only two hormones which are released. So definitely this will be a question in your medical exams. So it is from the posterior pituitary, there are two hormones released. One is oxytocin and the next is ADH, right? So this is how ADH is secreted. This is from where there is ADH is secreted. Now we shall discuss the mechanisms of ADH, how ADH functions exactly, how ADH works on the renal tubule, right? If I take your, this one, this is your neuron, I'm sorry, this is your nephron, so not neuron. Output, where you excrete the urine, right? So this is your nephron and this is just a schematic representation. So the cells which are located, this is the distal convoluted tubule and this is your collecting duct. So the cells which are lining the distal convoluted tubule and the cells that are lining the collecting duct, these cells are named as principal cells. Principal cells. Cells are located in DCT as well as the collecting duct. So this is your DCT, distal convoluted tubule, and this is the collecting duct. Now if I take out one principal cell and represent it here, and then we shall discuss how this ADH is working on this principal cell. This is your collecting duct, right? This is your duct, and lining your collecting duct there are principal cells. So these are your principal cells. So let me enlarge one principal cell here. So this is one principal cell, and at the same time on the other side there is no need to enlarge here. Look, these are the principal cells. From here, this is the terminal portion of the collecting duct where the urinary output is done. Look, now lumen, right? And this is the lateral sides. So this is the lumen. This is the lumen. So the membrane that is lining the lumen is called as the luminal side, and these are the lateral sides. These two are the lateral sides, and this is the basal side. So this entire thing you call it as basolateral membrane, and this one that is facing the lumen is called as the luminal membrane, and this part of the cell which is lateral as well, which is having lateral borders as well as the basal one is called as the basolateral side. Why is it important? Because there are some special channels which are located in these cells. Look, on the this one on the luminal side you will have special channels. These channels are named as, look, this is here, okay? On the basolateral side also there are multiple channels. Even on the basolateral side there are multiple channels. So these are the channels which are different from these channels. So these channels are named as aquaporin 1, and these channels are named as aquaporins 2. So if I ask you where are these aquaporin 1 exactly located, then you need to tell that they are located on the luminal side of the, or luminal part of the principal cell, or luminal side of the principal cell. If I ask you regarding the aquaporins 2, then you need to tell they are located on the basolateral part of the principal cell, right? So these are aquaporin 1s and these are aquaporin 2. Now, structurally when we speak, aquaporin 1 molecules, right? Structurally when we speak, aquaporin 1 molecules are generally closed. Look, there is a gate here. These are generally closed. Unless and until these aquaporin molecules are activated, they don't open. Under normal conditions, aquaporin molecules are always closed. And under normal conditions, aquaporin 2 molecules are always open. They are not closed. So this is the main structural change, structural difference between aquaporin 1 and aquaporin 2, right? Now, water. You know, you excrete daily around 500 to 3005 ml of urine. It contains a lot of waste materials, lot of sodium, ions, electrolytes, even water as well, right? So water as it is passing down, look, this is the water, and water as it is getting excreted out of your urinary output, look, water as it is getting excreted out, it is reabsorbed back. How? It happens only, this reabsorption of water happens only under the action of ADH, or anti-diuretic hormone. Look. First let me explain you the mechanism, and later on I'll explain you why water has to be reabsorbed instead of excreting out. Fine? Look. As water is passing down, first of all here there are receptors. Principal cells have multiple receptors. These receptors are called as ADH receptors. These receptors are named as ADH receptor, anti-diuretic hormone receptors. Now the moment ADH attaches to these receptors here, the principal cells get active. When the principal cells get active, they open up these channels. As I told you, aquaporins ones are generally closed. So the moment these cells are activated under the action of ADH, the gates are opened. The gates are opened, the water which was passing before outside of your body now enters in this way. 100% of water, but around 60 to 70% of the water enters back, or reabsorbed, correctly speaking, reabsorbed back into the cell. And from the cell, as I told you, aquaporin 2 molecules are always open. From the cell, they reabsorb back into the blood. ADH helps in water reabsorption. Now, why water has to be reabsorbed instead of excreting out? Why not excreting out? Why it has to be reabsorbed back into the blood? The answer is that, look, as I told you, then every minute your cardiac output is 5000 ml. Right? Every minute from your left ventricle, 5000 ml of blood is pumped. You know, blood contains water as well, water, electrolytes, and etc. etc. For example, in a patient, if the cardiac output is too low, instead of 5000 ml, if the cardiac output is 3000 ml, so he is having a loss of 2000 ml, right? So in this lost state, do you really think he need to excrete the water out of his body and lose the remaining part? No, he should save as much water as possible. He should conserve as much water as possible. In this lost state, even if he starts excreting water, you know what happens? Initially he is having 3000 ml, right? Low cardiac output. If he starts still more excreting water outside his body in the form of urine, from 3000 it will fall back to 2000. The body fluid, from 2000 it will fall back to 1500. From 1500 it will fall back to 1000. Where is 5000 and where is 1000? This is absolutely low volume state in his body. So you call this condition as hypovolemia, low volume. Hypovolemia can also lead to hypovolemic shock, later on coma, and later on death. So to prevent all these, ADH helps. ADH helps in regulating the water balance in your body. Whenever your body is scarce of water, ADH does not allow the water to excrete out. Instead, it reabsorbs the water back into the blood. So this is how ADH works, and this is the main function of the ADH, right? Now we shall discuss some clinical points. Look, in some conditions what happens is there is hypersecretion of ADH, and in some conditions there is absolutely absence or low secretion of ADH. Hyposecretion or hypersecretion of ADH. Now first of all we'll discuss what conditions causes the hyposecretion of ADH. Look, this is the ADH receptor, right? Okay, for example, take a case. For example, if there is a patient who is having cardiac output, instead of having 5000 ml, he is having 3000 ml, right? Now in this patient, ADH has to work, because in this patient losing extra water is not considered, because if he loses extra water, as I told you, it leads to hypovolemic shock, right? So in this person, in this patient, ADH has to come into action. Now if the receptor here is not functioning properly, can ADH attach? No. Can the cell be activated? And can the channels be opened? No. So he loses water. When he loses that remaining amount of water, as I told you, the same situation, hypovolemic shock. Next thing, if there is any trauma, any road accident, any trauma for your hypothalamus, if the hypothalamus is damaged completely, right? Look, as I told you, this is your hypothalamus hanging down. There are two things, anterior pituitary and posterior pituitary. Now if this connection is cut off, will they secrete ADH? No, they don't secrete ADH. Now in that condition also there will be water excretion instead of reabsorption. You're getting it? And the third condition, for example, if a person is using drugs such as declomycin, look, this is an important one. Declomycin. Declomycin is generally used for urinary tract infections, right? It is generally used for urinary tract infections, but if the person is administering these drugs repeatedly, then it causes the damage of the pituitary. So as a result, again ADH is not produced in the same scenario. And during in the pregnant woman, in a pregnancy condition also, ADH levels are decreased because during the gestation period of 40 weeks, continuously every day there will be production of an hormone called as vasopressinase. Look, is this it's not a hormone, sorry, it's an enzyme. Vasopressinase is an enzyme that is released by the mother during the gestation period. Now, what happens is this vasopressinase cut down the anti-diuretic hormone. It cut down the chains of anti-diuretic hormone and inactivates it. Now, when anti-diuretic hormone is cut down, when the chemical bonds are cut down, then anti-diuretic hormone is no more active. So, as a result, it cannot function here, right? And so these are some of the issues. This is the etiology exactly to say how ADH levels can be decreased. Coming to the signs and symptoms, for example, if there is low production of ADH in your body, as I told you, right, there are many ways through which ADH can be the production of ADH can be lowered. Now the signs and symptoms are, look, if the person, instead of reabsorbing water, if he is excreting out totally, what happens? The first thing, as I told you, hypovolemia. Let me write here, it's important. Look, there will be, first thing, if he is excreting out lots and lots of water, there will be hypo. Second thing, when there is a loss of water from his body, there will be dehydration. This causes the thirst center in your cortex to get activated. And when your thirst center activates, then the person feels thirsty. Poly. Yeah, dipsia in the sense thirst. Excreting lots and lots of water, then you call it as, this condition is called as polyuria. In a day around 4 to 24 liters of water is excreted. If there is no proper secretion of ADH, daily 4 to 24 liters of water is excreted, and this condition is called polyuria. When water is keeping on excreted out, when water is excreting out in lots and lots of amount, it causes dehydration and the person feels so much thirst, and this condition is called as polydipsia. So both of them result in hypovolemia, right? And one more thing, when water is lost from your body, what about the blood pressure? Blood contains water, right? If there is 5000 ml of blood in your body, every minute cardiac output is 5000 ml, then your blood pressure will be 120/80. If your blood volume is decreased, of course blood pressure also will be decreased. There is no logic in that, right? So in the same way as he is excreting lots and lots of water, then the blood volume also from 5000 it will fall back down, right? So as a result, pressure will be decreased, blood pressure will be decreased, blood pressure will fall below 120/80. So this condition is called as hypotension. You know about what I explained all this? All these are the symptoms, and previously I explained with the etiology also. Because etiology and symptoms, all these are of diabetes insipidus, a condition called as diabetes insipidus, in which there is low production of ADH. Diabetes insipidus can be caused by various etiologies, as I told you, trauma, as I told you, damage of the pituitary gland, as I told you, the constant intake of declomycin in gestation period. In all these cases, there will be hypoproduction of ADH, resulting in all these symptoms, and this entire condition is called as diabetes insipidus. Now, in contrast to this, there is one more scenario. As I told you, in diabetes insipidus, there will be low production of ADH. Now, in another case, there will be hyperproduction of ADH. Now, this hyperproduction of ADH, you call it as, this condition you call it as syndrome of inappropriate ADH, SIADHS. S stands for syndrome. Let me write it here. Look. Inappropriate. No proper release of ADH. There is abnormal release of ADH, heavy rush of ADH release. Appropriate. Syndrome of inappropriate ADH. This syndrome later, because this is an important syndrome, so I need a lot of time to talk about it. But as far as ADH is concerned, so these are the important things which I discussed, and if you understood this concept very well, then definitely there will be a mark in your pocket, right? So this is Krishna signing off Menko Tutorials. Happy New Year.